Good day. Today we want to explore the neurobiology of mental illness. In particular, we're going to look at three conditions: schizophrenia, depression, and addiction. Let's begin by giving a definition of mental illness. This actually could be a topic that could take up an entire lecture trying to define mental illness. What is mental illness? One definition put out by DSM-5, the Diagnostic Statistical Manual of Disease, coming out of the American Psychiatric Association, says that a mental disorder is a syndrome that's characterized by clinically significant disturbance in either an individual's cognition, emotional regulation, or behavior. And it reflects a dysfunction in the psychological, biological, or development processes underlying mental dysfunction. Such disorders are usually associated with significant distress in social, occupational, or other important activities of life. And so there we see three components of mental illness. It has to do with something regarding the mind, be it cognition, emotion, or behavior. Now we consider that it involves an underlying psychobiological dysfunction. And thirdly, it should have an impact upon your normal everyday functioning. Now, within the context of mental health and mental disorders, there are two significant issues that I want to highlight before we go into looking at specific disorders. The first has to do with epidemiology. It's been estimated that almost 1 billion people worldwide have a mental or substance use disorder. This diagram or this chart shows areas according to their prevalence. And we can see that there are some regions of the world where the prevalence rate is as much as 20%. In other regions where the rates seem lower, there may be issues with diagnosis and reporting. So these figures could actually be much higher. In addition, just to the existence of mental health disorders among the population, they have a tremendous cost. The World Health Organization has developed a measure called the Disability Adjusted Life Years to come up with a way of estimating disease burden. This value, called the daily, encompasses two measures: the years lived with the disability and the years of life lost to the disability. So let's think about someone who gets depression at age 20. And let's imagine they live till age 60 suffering with depression. Then they live 40 years with that disability. Let's also imagine that the average life expectancy for that person was 70 years, and that something about their depression caused them to lose their life. They then lost 10 years of expected life. So their daily there would have been 40 years lived with a disability, plus 10 years of life lost, total of 50. Now let's take another individual, and let's imagine they developed heart disease at age 50. Let's also imagine that they died at age 65 due to complications from their heart disease. So they lived 15 years with the disease, and their years of life lost was 5. Their daily, in that case, would be 20. And one of the reasons why mental health disorders are such a disease burden is they're often considered the chronic diseases of young people, because many of the more common mental health disorders, such as mood disorders, anxiety disorders, schizophrenia, actually start very early on in life, in adolescent years. And then we don't have cures for these disorders as yet. And so persons live with them for a very, very long time. So if you just look at mental health disorders, then we can say that some statistics show that they represent almost 15% of the global disease burden, which is more than heart disease and cancer. This slide has many statistics related to mental health disorders. I'm not going to go through them, but you can pause this video and you can just look at some of these statistics to just give you a sense of the massive impact mental health disorders are having on global society. And therefore, any discussion about mental health disorders must recognize their impact upon society and why it's urgent that we understand them more. The second thing, or the second issue that I want to highlight about mental health disorders leading into our discussion is the fact that many persons now suggest that mental health disorders are due to underlying brain dysfunction. Now, this might seem obvious, but it really is a fairly new perspective. For many, many years, persons with mental health disorders were stigmatized, and they're still stigmatized today. And it was suggested that mental health disorders were a result of a moral failing or a character weakness, and people just couldn't control themselves. Now it's being suggesting that the challenge with mental health disorders is something has gone wrong with the brain. And unfortunately, despite the massive advances in brain science over the last 20 years, the brain still remains the least understood organ, making it very, very difficult to fully understand mental health disorders. Let me give you a simple example. If you think about the symptom of chest pain, and someone presents to you with chest pain, that chest pain could be due to angina or heart condition. It could be due to acid reflux and a GI condition. It could be due to a muscle strain, a musculoskeletal condition. It could be due to pleuritis, a respiratory condition. 4 massive systems, all could be affected by the symptom called chest pain. And therefore, when someone presents with chest pain, you need to be able to have different diagnostic tests to determine what is the underlying dysfunction. Unfortunately, in the realm of mental health disorders, such diagnostic tests are often lacking. The image I have on the screen is a former director of the National Institute of Health for Mental Disorders in the US, Tom Insel. And he has a very good TED Talk exploring this idea that I would highly recommend you watch either before you continue my video or after this video. So let me give you one example of how, as we understand mental health disorders as brain disorders and how we look for diagnostic tests, it could change our approach. Much research has suggested that persons who suffer with schizophrenia might have a behavioral correlation that's associated with eyeball movements. If this is true, it might allow us to detect this earlier, and it also might allow us to measure the progress of the disease. The image shows a setup we can use, an experimental setup we can use to track eyeball movements as a person, a volunteer or a patient, traces a movement across a screen. Results have shown that for smooth pursuit movements, for free viewing movements, and for fixation movements, there are clear differences between persons suffering with schizophrenia and normal controls. And you can see that in the 3 images here: smooth pursuit movements, viewing a free photograph, and fixing on a single point. And people who have done this work have developed a mathematical model which they say can predict schizophrenia with over 90% accuracy. If such things are true, it might be able to be developed even further to predict persons at risk of developing schizophrenia and therefore allow earlier interventions. And so by beginning to view mental health disorders as brain disorders and looking for correlations like this one, it allows us to be able to define what's going on sooner and begin to treat the situation sooner. Okay, so let's look a little bit at 3 mental health conditions and then the neurobiology associated with them. Because many of these conditions are stigmatized, The first part will just describe the condition so you understand it and seek to clarify certain misconceptions before we look at the neurobiology. And the first thing we're going to look at is schizophrenia, which is perhaps one of the most debilitating mental health disorders. Now, this is a chronic disorder that affects almost all aspects of cognition and behavior. Let me say that schizophrenia is not multiple personality disorder, and it doesn't mean split personality. The word actually refers to a splitting or a loss of touch with reality. And that seems to be what happens in schizophrenia. When persons are having active psychotic episodes, it seems that they have lost touch with reality and what's going on around them. Schizophrenia appears to affect approximately 1% of the population globally. Most studies suggest men and women are equally affected, or perhaps men are just slightly more affected by women. And men seem to have an earlier prevalence rate, an earlier peak onset in the late adolescent years. Women seem to have two peaks in their late 20s and late 40s. It has been suggested this might be due to the effects of estrogen in women. Now, one of the ways of trying to understand if something has a neurobiological genesis is by looking at is there a genetic component to the disorder? And we can do that by doing twin studies. The most famous twin studies use twins that have been separated at birth, usually because of adoption. In this case, you have individuals with the exact same genes, but they're raised in different environments. And so it provides a nice template for exploring, is something genetically related or is it an environmental predisposition? When you do studies like this, we see concordance rate for monozygotic twins is over 40%. That tends to suggest that at least half of the components of schizophrenia have genetic linkages. And the more you are related to somebody who has schizophrenia, is the greater your chance of also getting schizophrenia. So if you have a sibling with one schizophrenia parent, chances are 17%. If you are a child of a person with schizophrenia, your chances are 17%. If you have a brother or sister with schizophrenia, your chance is about 9%, and so on, as you can see on this graph. What are the symptoms of schizophrenia and how is it diagnosed? As I mentioned earlier, one of the challenges associated with mental health disorders is we don't have diagnostic tests. And so we have to use a symptom manual in order to diagnose schizophrenia. Globally, there are two manuals that are most prevalent. The DSM-5, which is put out by the American Psychiatric Association, and the International Classification of Disease, which is put out in Europe. DSM-5 suggests that schizophrenia consists of the following, two of all which must be present: delusions, hallucinations, disorganized speech, disorganized behavior, and negative symptoms. And at least one of these two must be either delusions, hallucinations, and disorganized speech. Those first three, delusions, hallucinations, and disorganized speech, they make up a group of symptoms called positive symptoms. And these refer to symptoms that are present but should not be present in the normal person. That's what we mean by a positive symptom. Negative symptoms refer to characteristics of the individual that are absent, that should be present, like emotional expression and socialization. And finally, we know that in schizophrenia, there are also cognitive symptoms. So let's look at these in a little bit more details. Positive symptoms. An hallucination is a false sensory experience. For example, hearing voices. That would be an example of an hallucination, hearing voices that are not there. That would be typical of a psychotic episode in schizophrenia. Studies have now been done on persons actively experiencing psychosis when they're hearing voices. And what MRI studies show, fMRI studies show, is these patients are actually seeing activity in Wernicke's area, the area of the brain that does process the sound associated with voices. And so even though these voices are not real, what is real is some activity is going on in the brain that processes voices. And that's why these persons are hearing the voices. Again, indicating that the underlying dysfunction in schizophrenia is something has gone wrong within the brain. What about delusions? Well, delusions are fixed, false beliefs that have no bounds or no anchor in reality. There are many types of delusions: delusions of persecution, delusions of grandeur, delusions of people putting thoughts in your mind, people stealing your thoughts. All of these are examples of delusions that can happen during active psychotic episode. And the third component of positive symptoms are disorganized thoughts and disorganized speech. Here we have one patient writing about his experience. He says, "My thoughts get all jumbled up. I start thinking or talking about something, but I never get there. Instead, I wander off in the wrong direction and get caught up with all sorts of different things that may be connected with things I want to say, but in a way I cannot explain. People listening to me get more lost than I do. My trouble is that I've got too many thoughts." That's interesting. You might think about something, let's say an ashtray, and just think, "Oh yes, that's for putting my cigarette." But I would think of it, and then I would think of a dozen different things connected with it at the same time. And this jumbling of thoughts then gets manifest in their writing and their speech, as you can see in the image. And so in their speech, they can make up new and meaningless words by just combining words together. Or they have loose associations where they seem to jump from topic to topic, and it's very difficult to follow what they're trying to say. And so there we see the three examples or the three types of positive symptoms: hallucinations, delusions, disorganized thoughts and speech. Positive symptoms are symptoms that should not be there. They're present, but they should not be there in the normal condition. Well, what about negative symptoms? Well, we said negative symptoms are characteristics that should be present, but they're absent. Examples are flat affect, no emotional responses to stimuli. So whether someone tells a joke or whether you're at a funeral, your emotional expression is the same. Another thing that could be absent is interest in taking care of yourself and the usual grooming routines and hygiene that is expected of people in society. Another one is alogia, poverty of speech, speech that lacks content, an unwillingness to talk, withdrawal from social contact, and finally anhedonia, an inability to experience pleasure from normal daily routines that should bring pleasure. All of these are considered negative symptoms. And in schizophrenia, negative symptoms are often more difficult to treat and often last longer and way beyond the psychotic episodes associated with positive symptoms. And the final thing that we want to talk about is cognitive symptoms, because these have been gaining more and more attention as we recognize that cognition is also affected during schizophrenia. Because of the predominance of the psychotic episodes and the negative symptoms, this would have been understudied. But we now know in schizophrenia, there's a problem with thinking and processing information. And persons with schizophrenia can have difficulty focusing or paying attention. They can have problems with working memory. And they also have difficulty with executive processing, filtering and organizing information and making decisions. Now, there's a well-known English artist, Louis Wayne, and he was famous for painting cats. he developed schizophrenia. And so he painted cats at different stages of his illness. And you can see from these images that at different stages, what he perceived in his mind as the cat was very different. Now, the exact sequence of these paintings is still a bit controversial, but many people suggest that what we're seeing here is as the disease progressed, his cognitive experience of viewing the cat changed, and that's what he painted. Okay, so having looked and spent some time defining exactly what schizophrenia is and what's the symptomatology associated with schizophrenia, let's talk about the dopamine hypothesis of schizophrenia and switch track a little bit and now begin to look and explore the underlying neurobiology associated with mental health disorders. The earliest hypothesis for schizophrenia is something known as the dopamine hypothesis, and it suggests that there's an elevation of dopamine in certain brain pathways. How did this hypothesis develop? Well, in the 1960s, two pieces of information came to mind. The first was the development of certain drugs called antipsychotics that blocked dopamine receptors, primarily the D2 receptor. And these drugs were shown to be successful in reducing the positive symptoms of schizophrenia, the hallucinations, the delusions, the disorganized speech. So of course, if you use a drug that blocks dopamine receptor and it improves the outlook or the symptoms in the disease, you begin to think the problem is too much dopamine. To support this, it was known that certain drugs of abuse like cocaine and amphetamines that lead to increases in dopamine in the brain can also induce psychotic states with hallucinations and delusions. So now we have two pieces of evidence. Drugs that block dopamine improve positive symptoms, and drugs that increase dopamine lead to psychosis and the presence of positive symptoms. Of course, this would have then led to a lot of work around dopamine. And then many studies were done, and some of which showed evidence, some of which did not show evidence. So overall, these results are probably inconclusive. Some patients do show increased levels of dopamine in the CSF and metabolites in the urine. And some patients have shown at postmortem increased dopamine receptor density. And of course, many other studies, PET studies and fMRI studies have tried to look at these things. So based on that, the dopamine hypothesis of schizophrenia suggests that there are two particular pathways in the brain that we want to focus on. Now, we do know that the mesolimbic pathway, which runs from the midbrain, the ventral tegmental area, and the mesocortical pathway, which also runs from the midbrain, both use dopamine. The mesolimbic pathway goes to the limbic system, and the mesocortical pathway goes to the prefrontal cortex. It's now believed that an increase of dopamine in the mesolimbic pathway is what's responsible for the positive symptoms of schizophrenia. And that's why when you block the mesolimbic pathway, or you block the dopamine in the mesolimbic pathway, you get rid of the positive symptoms. However, these drugs don't affect the negative symptoms. So that suggests that the negative symptoms have nothing to do with too much dopamine. Now, it has been suggested that the mesocortical pathway, as you can see here, inhibits the mesolimbic pathway. Now, if that is true, some people suggest that the problem starts in the mesocortical pathway with a reduction of dopamine here. This removes the inhibition to the mesolimbic pathway, making it overactive. So let's follow what happens. There's some brain injury. That brain injury leads to dopamine neurons in the prefrontal cortex being underactive, and that gives the negative symptoms of schizophrenia. These neurons usually inhibit the mesolimbic pathway, because that inhibition is removed, this pathway now functions too much, and that leads to the positive symptoms of schizophrenia. There is some evidence to support this, but of course, it's not been conclusive. What are some of the problems with just saying that it's dopamine? Well, not all patients that receive antipsychotic medication demonstrate improvement. So then we can't just say in all cases the problem is dopamine. But then, of course, remember what I told you at the beginning. Could the symptoms of hallucinations and delusions actually reflect 2 or 3 different disorders, just like chest pain reflects 2 or 3 different disorders? Secondly, the onset of these drugs working often takes weeks. There's an initial response, but the full response often takes weeks, again suggesting it's not simply blocking dopamine receptors. And then, since the development of the original first generation antipsychotics, there have been other antipsychotics that have been developed that don't only work on D2 receptors, but affect other neurotransmitter systems like serotonin. And these help with the negative symptoms. Taken together, the fact that dopamine blockade does not affect the negative symptoms, but affecting other transmitters affects the negative symptoms, suggests that something is up, and it's not simply dopamine. Then, other drugs that do not increase dopamine can cause psychosis. In particular, a drug called phenylcyclidine, which blocks the NMDA receptor. And finally, as I mentioned before, a lot of the clinical findings are inconsistent and don't always support an increase in dopamine. And so overall, the dopamine hypothesis still has traction. But today, most scientists suggest that the original dysfunction in most cases of schizophrenia is not dopamine. Just to recap, the current treatment for schizophrenia revolves around blocking neurotransmitter receptors, and in particular dopamine. The first generation antipsychotics, of which chlorpromazine and haloperidol are typical examples, block D2 receptors. But a whole new generation of antipsychotics have been developed, which also have activity at serotonin receptors and D4 dopamine receptors. And these have shown good success with the negative symptoms of schizophrenia. Now, one of the challenges with antipsychotics blocking dopamine receptors is there are other dopamine receptors in the brain. The tuberoinfundibular pathway, which regulates the production of milk from the mammary glands, involves dopamine. Usually, prolactin stimulates this activity of milk production. And prolactin is inhibited by dopamine in the tuberoinfundibular pathway. Therefore, if you block dopamine, you release the inhibition on prolactin and you get galactorrhea, a side effect seen in patients taking first generation antipsychotics. You can also get breast enlargement, gynecomastia. And you can imagine that would be very disturbing to patients. Remember, we also have dopamine receptors in the basal ganglia. So blocking these receptors can create pseudo-Parkinsonism with all the features of Parkinson's disease. And you also get other strange movement disorders like tardive dyskinesias, which involves tremors and several involuntary movements, especially of the face and the mouth, as shown in the image before you. Many of these antipsychotics also affect other systems in the brain, leading to sexual dysfunction, weight gain, and drowsiness. And so a major challenge with treating schizophrenia is the current drug treatments have many side effects, and often patients don't want to take them, and therefore compliance is an issue. Finally, there's one important side effect that is not very common but can be deadly, called neuroleptic malignant syndrome. This is an adverse reaction to antipsychotic drugs and can develop suddenly within the first couple of weeks of use, in which there's sudden high fever, excessive sweating and unstable blood pressure, the muscles become very, very rigid and there's extensive autonomic dysfunction. This is an emergency that needs to be treated right away. The antipsychotics stopped and treatment given to lower temperature and reduce muscle rigidity. Okay, let's just mention a couple of the more recent theories of how schizophrenia might originate. The next theory is the glutamate hypothesis of schizophrenia. Now, the glutamate hypothesis suggests that the underlying dysfunction is a hypofunction of glutamate receptors. Remember I mentioned to you that PCP, phenylcyclidine, which is also a street drug called angel dust, blocks the NMDA receptor. And when you do that, you get both positive and negative symptoms of schizophrenia. Now, these glutamate receptors are often found in the prefrontal cortex, and they inhibit the mesolimbic pathway. So the term hypofrontality has been developed, which suggests that there's some injury in the prefrontal cortex that reduces glutamatergic function. This leads to negative symptoms. That loss of glutamatergic function releases inhibition on the mesolimbic pathway, leading to too much dopamine hit and the positive symptoms. And PAT studies have shown that hypofrontality does exist in some persons with schizophrenia, though, again, these results are not conclusive. Of course, this opens up a whole realm of activity for studying different interventions and different pharmacological responses to treating schizophrenia. And finally, what about the fact that schizophrenia presents itself during adolescence? Some persons suggest that schizophrenia is a developmental disorder. Evidence for this is from the fact that persons who get diagnosed with schizophrenia, when you look back in their history, you see abnormal behavior from home movies and school records. And so it has been suggested that schizophrenia is a result of a trauma that's experienced either before birth or around the time of birth. This trauma doesn't become apparent until later on in life, maybe when a stressor presents itself during adolescence, or this trauma starts a process that only manifests clinically when a certain amount of neuronal damage has been done, which occurs at adolescence. This here highlights the importance of early detection and early intervention. So for example, if there's some trauma that leads to a loss of neurons and cortical synapse, as is shown by these studies, if we can pick that up before the schizophrenia presents at age 19 or 20, maybe we can intervene here and help treat the disorder beforehand. Much like if we know somebody's predisposed to a stroke or heart attack, we can prescribe blood thinners and prevent these things. This idea then speaks about something called the gene-environment interaction. The fact that around birth, something can happen, a traumatic birth, a virus exposure during the first trimester. And this then acts upon the unique genetic milieu of any individual and increases their vulnerability to schizophrenia. And then that person, if they get exposed to a stressor later on in life, they don't have the capacity to withstand that stressor. And the result is they now develop full-blown schizophrenia. So taken together, that puts us with three clear hypotheses for schizophrenia that perhaps work all together. The dopamine hypothesis of schizophrenia, the glutamate hypothesis of schizophrenia, and the developmental hypothesis of schizophrenia that talks about gene-environment interactions. And of course, you can see here the value of understanding neurobiology, because the more we can nail this down, it's the more we can see it in different people are different things happening, and how can then we best treat different individuals. Okay, let's talk now a little bit about depression. Now, depression and anxiety are the most common mental health disorders. Depression is a disorder of mood and it's part of a wider group of disorders called mood disorders. Now, mood refers to a pervasive emotional state that influences how you view yourself and your environment. And it refers to an emotional state over a long period of time. Mood is to emotion what climate is to weather. What do I mean like that? Well, in the Caribbean, we have two seasons related to climate, the dry season and the rainy season. Each lasts approximately 6 months. During the dry season, you can't have a rainy day. So the weather today is rainy, but the overall season that you're experiencing is the dry season. Just like you could have a warm day during winter. On that particular day, the weather is warm, but you're actually during the season of winter. So a mood describes what's your pervasive emotional state over 3, 4, 5, 6 weeks, 2 months, 3 months. In that time, there could be one day where you're happy, but your overall mood is sad. Now, depression is one of the major leading causes of disability worldwide, and it's the #1 mental health disorders on some lists. Just like schizophrenia, it commonly starts in late adolescence life. And unlike schizophrenia, it's much more common among women than men, with a ratio often at 2 to 1. A major depressive episode, as diagnosed by the DSM, has several features to it. There's depressed mood or loss of interest or pleasure in activities. And then they must have some of the other symptoms that are listed here: a change in appetite, sleep or psychomotor activity, decreased energy, feelings of worthlessness and guilt, difficulty thinking, recurrent thoughts of death and suicide. Again, note how we're having to use symptomatology to make a diagnosis. And the chart you see there shows that if you have one depressive episode, you have a much higher chance of getting a second. And if you have 2, you have a much higher chance of getting a third, indicating we haven't found cures to these disorders. Again, just like schizophrenia, there's a strong genetic component. And again, using twin studies, we find that the genetic component in depression is actually greater than schizophrenia, reaching up to 70% at certain times. So, what about the neurobiology of depression? Well, just like schizophrenia, our earliest understanding dates back to the 50s and the 60s, when a particular drug was being used to treat hypertension, and that drug was called reserpine. Now, hypertension was believed to be due to too much monoamines like noradrenaline and adrenaline circulating. So this drug, reserpine, is known to deplete monoamines, and so it was given to treat hypertension. But what it was found was that in many patients who were given this drug, even though their hypertension came down, their blood pressure came down, they developed a depressive state. And so the theory became that too little monoamines leads to depression, too little noradrenaline and adrenaline. This led to the development of drugs designed to boost monoamines, and these became first-line treatments for depression. In particular, tricyclic antidepressants that prevented the reuptake of noradrenaline and adrenaline, and monoamine oxidase inhibitors that prevented the breakdown of noradrenaline and adrenaline were developed and were used to treat depression with some success. However, there is evidence that this is not simply the entire story, that depression is because of low monoamines. For example, the response to the monoamine inhibitors and the tricyclics is slow and often takes several weeks. You can deplete monoamines in healthy individuals, and they will not necessarily get symptoms of depression. You get variability in the levels of serotonin, adrenaline, and noradrenaline between patients and between normal people. And some depressed patients even show high levels of noradrenaline. And so again, is not so simple as just saying the elevation or the depression of one particular neurotransmitter in the brain. What we now know is that many treatments for depression seem to be able to produce neurogenesis in the hippocampus. And so it has been suggested that the problem in depression is there seems to be destruction of neurons in the hippocampus. And that if we can regenerate these neurons and boost the transmission of a particular factor, brain-derived neurotrophic factor, that this can help with depression. Now, interestingly, stress is one of the major factors that causes degeneration of hippocampal neurons and lowers BDNF. And so there's been a lot of work looking at the fact that, well, maybe is the causative factor in depression stress related. Now, this would have started with looking at persons who have a particular disorder called Cushing's syndrome, in which there's an adrenal tumor and the body produces too much cortisol and other glucocorticoids. And these persons are prone to depression. When you actually look at people suffering with depression, they generally have high levels of circulating cortisol. And other work has suggested that persons with depression have an enlarged pituitary gland. They have high levels of corticotrophin releasing factor. They have low levels of CRF receptors in the brain. They have adrenal gland enlargement. They have excess cortisol in the urine. Their dexamethasone suppression test is abnormal. All of which suggests that there's some level of derangement in the stress axis, the HPA axis. And so now the current theory behind depression is not simply the monoamine theory, but it's called a stress diathesis model, much like schizophrenia. And what it suggests is that people have a particular genetic vulnerability to depression. And if they experience stressful life events, they're not able to cope with them in the same way. And this leads to disordered brain pathology and the symptoms of depression. Here is an example of one study looking at a particular gene associated with serotonin transport. This gene has three expressions or three ways in which it can exist. You can have the LL form, the SL form, and the SS form. What you will see is that depending on which particular pattern of gene you have, if you're exposed to stressful life events, your chance of getting depression changes. If you have the SS form and you're exposed to 4 life events that are very stressful, a death in the family, divorce, major illness like cancer, you have almost a 4 times greater chance of getting depression than if you have the LL form. And if you look at it in terms of attempting suicide, it actually is also very, very similar. And so this is the idea then behind what's going on in depression. Again, something's happened in the brain. It could be genetic or it could be abnormalities associated with birth. This makes you vulnerable to the disorder of depression. And then when stressors arrive, you can't cope as other people do. And the end result is a psychological disorder, in this case, depression. Okay, so let's switch track a little bit, and let's look at something else. Now, at the beginning, I said almost approximately 1 billion people suffer with mental health or substance use disorders. Interestingly, we now consider substance use disorders a mental health disorder. Well, why is that? To understand that, we have to talk about natural reward systems in the brain. Now, we all experience something called a sense of pleasure. And this sense of pleasure is very important because it causes us to repeat behaviors and to have motivation to perform certain behaviors. And we now know that there's a particular pathway in the brain that's involved in creating the sense of pleasure, and it's called the natural reward system. And the key structures in that pathway start in the ventral tegmental area. involve attractive fibers called the medial forebearing bundle, which runs to the nucleus accumbens, and also then run to the prefrontal cortex. This pathway, if stimulated, produces a profound sense of pleasure. What are some of the things that stimulate this pathway? Well, eating, drinking, bonding, love, playing, all are examples of normal everyday activities that cause activation of this pathway. And you can see that these pathways, these activities, are vital for survival. And hence, that's why we get this natural reward. The sense of pleasure is a reward that leads us to want to repeat these particular activities. Now, early experiments on this pathway using operant conditioning showed that this pathway has a very powerful effect on behavior. In early experiments, an electrode was placed in the pathway and connected to a lever in a rodent cage. The animal would be exploring the cage and by chance would press the lever, and this would stimulate the pathway, causing this sense of pleasure. When the animal experienced it, it would quickly learn that if I press that lever, I get that sense of pleasure. And it would begin to repeatedly press the lever. In some cases, it would press the lever hundreds of times within an hour, get distracted from everything else, and become so focused that it could even die. That then began scientists thinking, could this be a model of addiction? And these early experiments have now been put forward widely as a model of addiction. I do just want to point you to certain videos on YouTube and certain studies that suggest that this isn't the best model. There's one that's been viewed many times by Johan Hari that talks about that, that says everything you've been told about addiction is wrong. It will be interesting viewing for those of you who are interested in addiction research. We now know that the key neurotransmitter involved in this natural reward pathway is dopamine. So you can see these studies here show very clearly that if exposed to food or sexual activity in the rodent, there's a massive increase, a significant increase in dopamine within these pathways. Hence, in the popular literature and the media, the idea that dopamine is your pleasure hormone. Well, this, of course, with the focus on addiction, led people to explore, well, what happens in these pathways when exposed to drugs of abuse? And we now know, as you can see by these graphs, that study after study have shown that drugs of abuse all lead to an increase in dopamine in the natural reward pathway. The actual mechanism by this, of how this occurs, has been worked out in many, many different cases. And it's now become pretty standard that almost all drugs of abuse, and even things like food, which I mentioned before, all of these activate the natural reward pathway and have the capacity to hijack the natural reward pathway. Drugs of abuse have a particular capacity to do this because of the massive release of dopamine. And this can lead to synaptic plasticity and changes in these pathways. And so, a small joke referencing an ad against drugs from the 1980s describing your brain on drugs. Really what happens when your brain gets exposed to drugs of abuse, it causes a hypersecretion of dopamine, which can give you a hyper-pleasurable state, which can change the wiring in your brain and then cause problems for you in a long term consequences. Of course, nothing in the brain is that simple. And we now actually know that the dopamine signal doesn't just signal reward, but more often than not, it's a reward prediction error. So if you just look at this little experiment and try and follow it, here's a monkey in which we're recording activity in the natural reward pathway. When the monkey is exposed to juice, you get a nice, you get a nice rise in firing. and that's associated with the presentation of the reward. Now, if you do some conditioning and that juice is associated with light, what you find is that the thing that leads to the increase in dopamine is not so much the reward itself anymore, but the prediction of the reward. And unfortunately, this seems to be what happens in addiction, where things that predict the arrival of the drug actually lead to this intense release of dopamine, which can produce cravings. But when the actual juice arrives or the drug arrives, you don't get the surge, and therefore it's a disappointment. And you go around in this cycle with things triggering the dopamine, leading to cravings, but then the actual arrival of the drug doesn't produce the high that the person was expecting. And the other reason why you don't get the high is also the fact that drug tolerance develops. Remember, I said that there's synaptic plastic changes that take place. And many studies have shown that the initial release of dopamine that gets triggered is much bigger than subsequent releases of dopamine. And that means the sense of pleasure associated is also decreased. And part of what appears to be happening in addiction is this constant chase and trigger and desire for that original sensation, which is very hard to achieve due to drug tolerance. So overall, what seems to happen in addiction is there seems to be some level of hijacking of the brain's system. In the brain, there's a balance between many systems. And one of the balance or the area of the brain that controls things ultimately is the prefrontal cortex, the area that makes executive decision making. But it seems that in addiction, because of plastic changes, the limbic system and that natural reward pathway begins to have a greater effect on decision making. And it outweighs the prefrontal cortex and now leads to impaired decision making associated with addictive behavior. This description that I'm giving you is highly simplified, and we know it's a lot more complex than that, but we still don't know enough, and there's great efforts being made to understand these things. Okay, so that brings us to the end of our tour of mental illnesses. Let me return to where I began. Mental illness is a big problem in today's society, affecting many of us. Unfortunately, because of stigma, many people don't want to talk about it or seek out help. However, without beginning to understand that mental illnesses have its genesis inside of the brain, the more we understand it and the more we can understand those changes, it's a better we're able to develop treatments and intervene. And so many scientists feel that the future is bright for the identification, the early intervention, and the treatment of mental health disorders. As always, keep safe, and until next time, take care.